Good afternoon, everyone. Thank you for coming to today's endocrinology grand rounds. We are very pleased to have one of our own faculty, Rebecca Jeun, present to us today. Rebecca joined us just over a year ago after getting her medical school training and also her endocrinology fellowship at Baylor College of Medicine in Houston with residency in internal medicine at Johns Hopkins. She had a couple of years of faculty experience at IU before she came here. And she has been an excellent clinician educator and has very rapidly grown the clinical practice and has been recognized for her teaching skills and also um, one of the most outstanding reviews from most of our patients who see her. She has presented to us before and has also been trying to develop some new programs, including in areas that are unique. Today she'll be talking about updates in the management of menopause. Um, just about maybe about 9 months ago or so, there was a special issue of Lancet that covered menopause, and it was titled, I mean, the editorial was titled "Time for a Balanced Approach to Menopause." And one of the things that they had mentioned out there was that um, there's all this difficulty in trying to explain these symptoms, and this group in Britain that wanted to uh, be included under disability. So they were successful, but then everybody said, so you made everybody who is uh, menopausal as a disability. So you consider that a disability now. So then they had to go back and try to change it to change the wording and everything. So there has been a lot of advances in understanding at multiple levels and also um, advances in management. And certainly, this is a topic that is very important to endocrinologists because people do come to us for some guidance on these issues. So we're happy to have her talk on this topic. Rebecca.
Alrighty. Well, thank you for Dr. Mokshagan for that kind introduction, and thank you all for being here in person and joining us virtually. And we'll be talking about some of the new changes and recommendations in terms of management of symptoms of menopause that can be very debilitating for many women. Okay, so I have no pertinent disclosures. I will be talking a little bit about some off-label usages of certain medications like gabapentin and different SSRIs in terms of the management of vasomotor symptoms of menopause. So just going over kind of the outline of my talk today, we'll go over kind of a typical case that shows up in the clinic, then go through the major changes in all the many organ systems that are affected during the menopausal transition. I'll discuss the pathophysiology of menopausal vasomotor symptoms, and then we'll spend some time talking about indications for menopausal hormonal therapy, risks and benefits, and then non-hormonal strategies, both pharmacologic and actually non-pharmacologic, in terms of treatment for some of these symptoms, and particularly vasomotor symptoms. Okay, so this is essentially taken from one of my recent clinic patients. The chief complaint was irregular cycles and hot flashes. 48-year-old female, otherwise pretty healthy, coming in for evaluation of irregular cycles. Menarche was at age 12. She was G2, P2. In the last year or so, cycles have started to become a little bit lighter and intermittently skipping. She's noticed a little bit more facial hair, not anything, that has been like really bothersome, but just something that, seen a little bit, a few more like under the chin hairs. And then the onset of night sweats, and she describes these as sort of originating as intense heat in the upper chest associated with sweating and palpitations. After kind of more questioning on review of systems, she's had more difficulty losing weight, some issues with brain fog, decreased libido, no galactorrhea, and no signs or symptoms of hypo or hyperthyroidism. Does have some history of migraines, but without aura, and no pertinent family history. She's a non-smoker, no drug use, no alcohol use. And exam pretty unremarkable. BMI is 31, no thyromegaly, some central adiposity. Pregnancy screen was negative. Essentially, those her labs were normal. Ruled out thyroid disease, no hyperprolactinemia, no hyperandrogenism. And then looking at gonadotropins, FSH wasn't particularly elevated in the early follicular phase, and estradiol also was in the normal range as well. Okay, so going to just kind of just a general overview. So menopause, we define this as a permanent cessation of menses, and this is a normal part of every woman's life cycle. And this reflects oocyte depletion and loss of gonadal steroids. Generally speaking, we'll use a definition of at least 12 months after the last menstrual period, but obviously you can have some patients who have like premature ovarian failure, patients who have undergone hysterectomy and oophorectomy who will have, surgical menopause essentially. This is preceded by a transition state, which we deem perimenopause, and that reflects a gradual loss of oocytes, some altered responsiveness to gonadal steroid feedback, and it's characterized by wide hormonal fluctuations and can be characterized as well by irregular menstrual patterns. Signs and symptoms can start months or years before, the actual menopause, and may last for several years afterwards. There's a lot of variability in terms of the lived experience of women, with some women essentially like my mother, just going through menopause and having absolutely no symptoms except for, her menstrual cycle stopped. And then, of course, we see in our clinic a lot of women have very debilitating hot flashes and other symptoms, irregular, like heavy bleeding, those kind of things. Okay, so just a review of the axis that we're talking about. So we're talking about basically the hypothalamic pituitary ovarian axis. And so you have your hypothalamus making gonadotropin releasing hormone in a pulsatile manner, stimulating the anterior pituitary, releasing luteinizing and follicle stimulating hormone, which triggers the ovaries and causes the changes in hormone levels that reflect themselves in the menstrual cycle, and also if someone gets pregnant, to prepare the endometrium for pregnancy, and then relevant changes on the mammary gland. So estrogen will have a negative feedback, but can also have a positive feedback at high enough levels to trigger ovulation. And so once we're getting into the closer to the transition stage, this is called the straw plus 10 criteria. And so this was kind of like a working group that characterized the different stages in perimenopause and the menopause transition. So essentially, they call this stage here stage -3, which is the late reproductive year. So during this phase, cycles are regular, maybe slightly irregular, normal to variable FSH, but ovarian reserve is starting to become lower. And then next stage is -2, or the early menopausal transition, characterized by over a 7-day difference in cycle length, variable FSH levels, again, low ovarian reserve. And then at the stage -1, this is the late menopause transition. So cycles are going over 60 days apart, FSH now more consistently elevated, again, still you would expect ovarian reserve is low. And then the +1 stage, essentially, menopause is here at this junction. We call this stage +1, early menopause, post-menopause. So menses have ceased, FSH is high, and ovarian reserve is very low to undetectable. And so, women can have different symptoms of throughout this whole transition, and then also into the postmenopausal phase as well. In terms of just focusing on the menstrual cycles themselves, so periods may become actually more or less frequent. People can also get heavier or lighter cycles, but eventually we would expect them to stop altogether. There are a few different factors that can be associated with differences in timing and duration of the transition. So higher BMI is associated with a later onset of the transition, but not the duration. And there's sort of a flattening of the fluctuations in estrogen levels. And then there are some racial ethnic associations. Black women may have longer duration of the transition than white women. Probability of ovulatory cycles tends to be lower in African American and Hispanic women compared to white and East Asian women. Smoking is related to earlier entry into the menopausal transition and shortened duration of the transition as well. Okay, so probably everyone's pretty familiar with a lot of the different signs and symptoms of menopause and perimenopause, but just to kind of go over these in a little bit more detail. So, hot flashes and night sweats can be a lot of kind of the primary complaint, but along with that, many women have issues with insomnia, and it may or may not be directly linked to the hot flashes themselves, but there's poor quality of sleep that you can see. A lot of times people notice difficulty losing weight and body shape changes, basically increased deposition of fat around the abdomen and changes in body composition, vaginal dryness, more discomfort with sexual intercourse, and then urinary changes, so increased risk of UTIs and urinary incontinence with decreased kind of lubrication of the vaginal mucosa, and generally other skin changes. Some people will note more dry, itchy skin, and then muscle pains, joint aches, and then a lot of women will describe, mood swings, irritability. There's been association with, depression, and then brain fog and reduced libido. Are all things that can be part of this transition period. Okay. So focusing a little bit more just on the vasomotor symptoms, so basically the hot flashes. So there's some different mechanisms that are postulated to explain these symptoms. And so because these symptoms can start before the onset of frank hypoestrogenism, it's also thought that these hot flashes can be basically a manifestation of declining hypothalamic sensitivity to estrogen. And so there's hypertrophy of a subpopulation of neurons in the infundibular nucleus, which are called the KNDY, or kispeptin, neurokinin B, and dynorphin neurons. And so these express the estrogen receptor and kispeptin and neurokinin B receptors. And so there may be increased signaling, and that is thought to be a contributory pathway to the effect of estrogen withdrawal and aging in terms of promoting hot flashes. And so that will come into play later when we're talking about some of the newer agents that have been developed for management of vasomotor symptoms in menopause. So what are some of the other organ system changes that we can see with menopause? And I'll go through several of these over the next couple of slides. So we do know that there are cardiovascular and metabolic changes. And so there's kind of multiple etiologies kind of going on from endothelial dysfunction, increase in reactive oxygen species, predisposition for more visceral obesity and dyslipidemia and inflammation related to that. And so we know that there is an increased risk of cardiovascular disease related to menopause and aging and women in this transition phase. And so on the right-hand side, this was taken from a study looking at basically the endothelium and its elasticity as measured by brachial artery flow mediated dilation in ultrasound. And so this study was looking at basically healthy women across all phases of the menopause transition. And essentially there was a clear decline in the endothelial vasodilation. And so related to stiffening of the arteries measured on this metric. So another thing we're all, I think, from the endocrine side of things, pretty familiar with are the bone density changes. And so just to kind of review, so as in our early adulthood, we're building peak bone mass and reach the peak in our kind of late 20s, early 30s, where there's a plateau. But as you get into the menopause timeframe, there is a period of rapid bone loss, usually within the first 5 years after onset, and then a more gradual decline over the ensuing decades. And so you can see that reflected in the fracture risk over time with age. And so this is broken down into T-scores, but you'll see basically as people get older, there is an increased risk of fracture, and bone mineral density testing becomes most useful in postmenopausal women, as you can see that the fracture risk does vary depending on T-scores for both vertebral and hip fractures. Okay, so other changes that people may note are things like breast reduction, tenderness, hair changes is common complaint. Mild hyperandrogenic symptoms can be due to relative androgen excess. Some women will note hair thinning and loss or change in texture. This next one was an interesting topic because one of my patients is an opera singer. And so she noted it's kind of a well-known thing in the voice circles and their literature that there are hormonal changes. I think they even have something called like a premenstrual voice disorder or syndrome. And there's also like a menopausal voice syndrome because there are sex hormone receptors on the laryngeal folds, and there's data to show that sex hormones do have some effect on voice function. So like vocal intensity, vocal fatigue, hoarseness, loss of pitch have been noted in menopausal singers, essentially. So just thought that was a little bit of a interesting side note, because that was the first time I'd really learned about that. And so, because of how many different, changes are occurring, this has obviously prompted a lot of studies in terms of kind of different aspects of the menopausal transition and their effects on things like cardiovascular health, cancer risk, and that kind of thing. So, of course, the big elephant in the room has been the Women's Health Initiative trials. This was from the 1990s, and it was looking at menopause hormone therapy and the risk of cardiovascular disease, certain cancers, bone density, other diseases. And so one of the takeaways was that combined estrogen progestin therapy was associated with increased risk of breast cancer and heart disease. There's been a lot of reevaluation of this data and trying to break down in terms of like population, who does this actually apply to? Because we're seeing that, more of the risk is in the older patients further out from the menopause transition. But due to the results of this trial, there was a significant decline in hormone therapy prescribing practices. There's some data that menopausal hormone therapy, there is data that we know now that we think that menopausal hormone therapy can be a safe option in younger, healthy women, and maybe depending on kind of timing of initiation, may be associated with lower breast cancer risk. Another kind of major study was the study of women's health across the nation, also from the 1990s, and this was a large study that enrolled 3,000 plus women from diverse racial and ethnic backgrounds, and has a lot of data, kind of a trove of data on bone health, cardiovascular risk factors, and ovarian hormones. So it's the source of a lot of our knowledge about the menopausal transition. Um, there were the MS Flash trials looking at antidepressants and moderate exercise and their effects on hot flashes and menopause-related insomnia. And then the KEEP study looking at timely menopausal hormone therapy and their effects on cardiovascular, cognitive, and mood outcomes within 3 years of the last menstrual period. So, women in that early postmenopausal period. And so this data showed no major adverse cardiovascular cognitive effects and no differences in breast cancer incidence. So again, supporting that menopausal hormone therapy seems to be a safe option in the right patient population. So just a little bit more about the Women's Health Initiative, and then another kind of related trial called the HERS trial. So this was so the WHI was looking at conjugated equine estrogen and medroxyprogesterone acetate, or conjugated equine estrogen alone in women without a uterus versus placebo. And so the combination arm was stopped early due to increased risk of invasive breast cancer. Conjugated equine estrogen alone or with medroxyprogesterone acetate was noted to increase the risk of blood clot and stroke, but reduce hip fracture risk. The combination also was shown to increase the rate of cardiovascular disease, but potentially protective effect on colon cancer. But again, we are needing to basically restratify based on age in terms of where we're seeing the highest risk of these adverse effects. And then cumulative long-term follow-up didn't show an increase in all-cause cardiac or cancer mortality from either treatment arm. And then in the HERS trial, this was a double-blind randomized control trial, conjugated equine estrogen, again, plus medroxyprogesterone acetate, looking at versus placebo in postmenopausal women with a uterus and coronary artery disease. So this ran concurrently with the WHI, and it was undertaken to look at hormone therapy as a secondary prevention for CAD. But there was a significant increase in the incidence of MI in the hormone therapy arm, but that seemed to plateau afterwards with no further risk or benefit. So that leads to some of the recommendations we'll talk about in terms of there's not really data to support using hormone therapy for cardiovascular risk prevention at this time. What I will say is that we are also moving, or I think it depends on, I guess, prescribing practice, but personally, I haven't seen conjugated equine estrogen used as much, and we're moving more towards transdermal estradiol and oral estradiol, which is different formulations than what were used in these studies. So this is some data on the impact of the Women's Health Initiative trial. Sorry if it's a little small, but essentially this is breaking it down by year. So on the left side, from the 1990s into 2007, so the dark black bar is use of oral estrogen replacement therapy, and then the horizontal bar in the middle is transdermal. And I think sorry, I'm even having trouble seeing the vertical bars here on the right-hand side are vaginal. And so you can see there was a significant decline in the oral prescribing practices, and then a relative increase in basically vaginal. And Tibolone is listed here as well as another agent. And then in this middle figure, this is a graph of, again, similarly, basically purchases of hormone replacement therapy by type among women aged 45 years and older. And so this line is the oral estrogen, and you can see there's again, significant decline over the same time frame. And then this is the rate of hormone replacement therapy by age group. And so the lowest rates were in the 45 to 54 range. And then we can see just basically across most of the age groups, the prescribing the rate of use has gone down over the same time frame. So I think so. With all that, prior to that, I think a lot of women were like, it feels like a lot of people were on estrogen and progesterone. But with that, the pendulum swung kind of in the opposite direction, where a lot of people didn't feel comfortable prescribing hormone replacement therapy, even in women who have had bothersome symptoms. And so now the pendulum, I think, is swung back more towards the middle, where it's a matter of choosing the right patient and making sure that they understand the risks and benefits, and more of a shared decision-making model. So what are the indications for treatment? So essentially, anyone with bothersome symptoms, particularly vasomotor, with menstrual and laboratory changes, and then also GU symptoms. So we'll talk over the next several slides about hormonal preparations, non-hormonal options, and then non-pharmacologic options as well. So generally, though, menopausal hormonal therapy will be the most effective in treating vasomotor symptoms and GU symptoms of menopause. And women with significant sleep or mood disturbances may also benefit from hormone therapy. I think you're seeing a lot of prescribing practices where people are going on therapy for maybe other reasons that are maybe not so much listed in guidelines, but things like joint aches and brain fog and those kind of things. But our current guidelines don't really kind of reflect that. The focus is mostly on vasomotor symptoms and GU symptoms that we can address. So again, like I was kind of talking about when we were discussing the WHI, so I think generally speaking, the data now suggests that hormonal therapy is safe and effective in low-risk women without underlying coronary artery disease or history of breast cancer, age less than 60 and less than 10 years out from menopause onset. And we do know, from the studies that hormonal therapy provides a very significant reduction in symptoms after treatment with estrogen and progesterone over placebo. So other considerations, like I had touched on briefly, we shouldn't be prescribing this for primary or secondary prevention of cardiovascular disease. The risk of breast cancer is something that needs to be discussed with the patients prior to initiation of hormone therapy. And so essentially, if the patient has a history of breast cancer or has a high baseline risk, like certain, genetic syndromes or, strong family history, other things that where they would be high risk of breast cancer, that's the patient that you would consider another non-hormonal alternative. The risk of breast cancer, and that's particularly with estrogen plus progestin, is incremental. And so therefore, a small kind of year-over-year increase. And in the guidelines, the consideration is that maybe 5 years of treatment is considered to be low risk, and extending beyond that is going to be a risk-benefit discussion with the patient in terms of how severe symptoms are, and whether or not to start tapering or adding in other non-hormonal alternatives. And then actually, in women without a uterus with estrogen alone, breast cancer risk actually was shown to be reduced in the Women's Health Initiative trial. Okay, so yeah.
This always comes up. So the hysterectomy only and giving the estrogen patch all the time, but they've had endometrial ablation. Would that be considered a reason not to? Although now they're met.
Yeah, no, that's a good question. So I didn't see that specifically, or I didn't look into that specific question, but I would think because they still have endometrial tissue, yeah, that I would be wary of that. But that's a good question for our OBGYN colleagues probably, who also end up doing a lot of this kind of treatment as well. But yeah, no, that's a good question. Sure. And so this is a chart of the different estrogen preparations. So I would say generally it seems like most commonly most folks are using 17 beta estradiol formulation. So transdermal is felt to be the safest in terms of the thromboembolic risk, and the 17-beta estradiol is supposed to mimic a biologic estradiol. And so there's a couple, several different brands out there, UofL, Clomara. And so depending on the brand are changed out once or twice a week. There's also oral estrase, and then topical. I don't use that commonly or haven't seen, but it's available. And then in terms of more local options for women who primarily have GU symptoms, vaginal estradiol is a good option. And there's, different brands and formulations. So for example, it's like an insert of a cream that is applied daily for 2 weeks and then spaced out. And then there's Premarin, which is a conjugated equine estrogen, some synthetic form, esterified estrogen, and ethinyl estradiol in oral form as well. And so like we talked about, if someone has a uterus, because you don't want unopposed estrogen leading to endometrial hyperplasia and risk of uterine cancer, you would be giving progestogen, some form of progesterone with the estrogen. And so there are oral forms, micronized progesterone, norethindrone, and medroxyprogesterone acetate. Some of these can be given cyclically, some continuously, and then some women in the perimenopause timeframe where perhaps contraception is still a concern, or there's issues with heavy, heavy and regular menstrual bleeding, an IUD, a hormonal IUD is an option as well. And then there's combination formulations, both so that contain both estrogen and a progestin, and these come in both. There's oral and patch forms. And several different brands. There's also forms with conjugated equine estrogen and medroxyprogesterone acetate, and then a medication called Duavi, which I've never actually used and don't have much experience with, but it's combined. The estrogen is combined with a SERM. So this is the goal is to remove side effects associated with the progestin, and it does antagonize the endometrial effect of the estrogen. Okay, so I think this is a topic that's been kind of more of kind of in on TikTok and like in the pop culture sphere is should we be prescribing testosterone for women? And is there a like androgen deficiency essentially that we need to address? So I think we still there needs to be a lot more kind of work on this particular arena. Essentially, right now there's not really any clearly established indications for testosterone therapy for women. The only really evidence-based indication may be treatment of hypoactive sexual desire disorder or dysfunction. And the recommendation is to have a formal biopsychosocial assessment, as there's a lot of different factors that can be playing into these symptoms in terms of the psychologic aspect, the relationship aspect, those kind of things. This is taken from like the Menopause Society kind of like consensus statements. And so the thought is that if the patient is diagnosed with this, potentially you could consider prescribing I think in the US, we really have access mainly to male formulation testosterone. And the goal would be to try to maintain hormone concentrations in the physiologic female range. So that means not to have patients do things like testosterone pellets that can really cause a significant amount of hyperandrogenism. And then the recommendation would be to get a baseline total testosterone at the start and then repeat level 3 to 6 weeks after, and essentially do a trial of like 6 months. And if there's not any benefit, then to stop that. But I think there's more work to be done looking at this particular question. Okay, so what are some of the non-pharmacologic interventions that can be considered? So weight loss may have a modest effect in terms of reducing some vasomotor symptoms, especially earlier in the transition. Diet and lifestyle changes haven't really been shown to have a lot of data in terms of a significant impact on directly reducing hot flashes and night sweats. Something I think that can always be discussed is sleep hygiene, promoting good sleep habits, and using things like white noise machines, keeping the sleeping area cool. Aromatherapy sometimes can help. And then there's a number of different sort of like mind, body, or psychological kind of approaches, including CBT, hypnosis, and then sort of working on mindfulness. And so, again, I think some of the data is kind of mixed on some of these things. Definitely, not harmful to suggest and may be helpful. So, but I think, a lot of people when they're coming into clinic will be looking for hormonal therapy or pharmacological therapy as in addition to some of these things, which can serve as adjunctive approaches. Okay. So what are the non-hormonal pharmacologic options? There is one SSRI that is the FDA-approved option for treatment of vasomotor symptoms in menopause, and it's paroxetine, but branded as Brisdell. If you're using the other branded forms, technically that's off-label, but essentially I think a lot of us will do off-label prescribing of SSRIs like fluoxetine or SNRIs like venlafaxine that have some data to support use in addressing vasomotor symptoms. So the newer agents are these neurokinin 3 receptor antagonists. So there's a selective one called fezolinetant that was recently FDA approved last year, targeting that signaling pathway, which we talked about in the beginning of the KDNY neurons. And we'll look at the data for that in a little bit. And then there's another drug in the same class and the NK receptor class, but it's a dual antagonist against neurokinin 1 and 3 called elinzanetant. I don't know how to pronounce that, but if approved, this would be the second non-hormonal option for treating moderate to severe hot flashes in this class. And so the data comes from the OASIS 1, 2, and 3 trials. Some of the other options for more localized genitourinary symptoms, there's a vaginal insert of DHEA called Intrarosa that has been approved, and that's particularly to address dyspareunia due to vulvar and vaginal atrophy. This is not like systemic DHEA or oral has not been approved for this reason. This is just the vaginal. And then some other off-label medications that can be considered would be things like clonidine for more mild symptoms and in a patient with hypertension. There's some data for antihistamines, but that's not well studied quite yet. And then gabapentin at nighttime, and then oxybutynin as well. Okay. So looking at the data for fezolinetant, the data for this comes from the Skylight trials. All these trials have fun acronyms, but these trials enrolled women aged 40 to 65 years old with an average of 7 or more moderate to severe hot flashes per day. And the inclusion criteria were that they had to have spontaneous amenorrhea for at least 12 months or at least 6 months with biochemical criteria of menopause, or had a history of a bilateral oophorectomy at least 6 weeks before the screening visit, and then BMI between 18 to 38. And so this was a placebo-controlled trial with an active extension period. And so it was looking at 2 doses, the 30 and 45 milligram dose. And basically in E on this left-hand side, we're looking at the percentage of patients who had a 50% reduction in their frequency and severity of their vasomotor symptoms. So you can see that, so this top line is the placebo. At most, it looks like 60% of patients had relief at the of at least 50%. And then on this side is looking at patients who had 75% reduction in their symptoms. And so it seemed like there wasn't much of a dose response, but it was significantly decreased compared to placebo. But you can see that there's a large chunk of the patient studied, did not have that significant of benefit. So some of the adverse effects include headache and GI disturbances, as well as elevations in liver transaminase levels. So that's something that will need to be monitored on therapy. Okay. So in terms of procedures, this is one of the things I came across that was newer to me. I hadn't really seen much data about this before, but there's some studies looking at stellate ganglion blockades. And so the procedure basically is using an anesthetic to block the sympathetic ganglia in the lower cervical and upper thoracic region. And the goal is or the thought is that it may modulate thermoregulatory areas of the brain. And so this data comes from very small randomized control trials, in the like less than like 50 patients or case series. And so reportedly there's reductions in moderate to severe vasomotor symptoms by up to 50 to 90%. And one block in some reports is suggested to last up to 2 to 5 weeks, and then repeated blocks providing sustained relief. There's not commonly side effects, but these can be pretty significant in terms of CNS complications like seizures, vascular puncture, basically local injury to structures around where the block is happening, and pneumothorax. So hopefully more to learn about this particular procedure. Okay, so going back to this same case, so looking at, her labs were, normal, but it seems like she's in the perimenopausal transition. So, would she benefit from some kind of therapy, assuming, we've ruled out other, we've ruled out thyroid disease, we're not worried about like a FeO, that kind of thing. So what would we suggest? So I think, for these situations, it's going to be, very individualized discussion with patients, because she's, potentially still ovulating if she is sexually active and there's risk of pregnancy. Some people will suggest using oral contraceptive pills, but she had a history of migraines without aura. So, there's some question about whether or not you want to do, combined hormonal oral contraceptives at that level. But let's say she didn't have the migraine history, that might be a reasonable option to then taper and then switch to the lower menopausal hormone replacement dosing once 12 months have passed since the last period. I think we're seeing now a lot of days more providers are prescribing, menopausal hormone replacement therapy even in this transition period. And then, things like gabapentin for hot flashes or some of the other non-hormonal options like paroxetine, could be considered. So it's not going to be a one size fit all kind of situation. And then, of course, the newer NK antagonists may be an option after, the final the full menopause transition. So, I think, women's health has always been perhaps maybe underrepresented. And so hopefully this kind of gave you an overview of some of the things that our patients are going through and come to us to learn more about it and see how we can best help them. But I think as with many things, there's a lot more to learn and to for us to think about as time goes on. So. Just to kind of summarize for take-home points, so I basically kind of the main thing would be in low-risk women who are less than 60 years old in early part of the menopause transition, I think hormone therapy is a safe and reasonable option for treatment of particularly vasomotor and GU symptoms. You do need baseline cardiovascular and breast cancer risk assessment. If you primarily just have GU symptoms, you can do local vaginal preparations of estrogen, and this doesn't require progestin use to be given along with it. the, I think patients will ask you about things like brain fog and weight loss and cardiovascular prevention. And I don't think we're quite at the point where we can, use that as our primary indication for prescribing. But it seems like there, can be a lot of benefits, particularly in the right patients. The combined therapy does come with a longer term risk of breast cancer. So that needs to be reevaluated with your patients over time. And the very symptomatic patients, people can still have severe hot flashes, several years after menopause, may require a slower taper and adding in non-hormonal therapies. There's some of the newer NK receptor antagonist agents that may be a reasonable option, although it seems like it's not effective for everybody. And then making sure we discuss some of the lifestyle measures that may have help. But we do have more, potent interventions in terms of hormonal therapy and also the other pharmacologic agents. And with that, I'll stop. So thank you all for your time and attention. And this is the CME code. Mhm. I'm sure there's different scoring systems, but so some of the different trials use like the number and frequency of hot flashes. So like for the NK receptor antagonist, they use like 7. I don't, so I think it's going to be some, clinical judgment in terms of, how severe. I mean, I think like patients are pretty good about telling you when they come to clinic, like I can't sleep, I'm miserable. So those generally, if that's like the reason that you're coming, I would be really thinking about, considering treatment options. But I'm sure in the different trials, they've used different metrics in terms of severity and frequency. Yeah.
People that are listening didn't hear the question.
I remember, I know Dr. Winters on the call, but there was something called a hot flash meter. They did in some of the studies. So every time we have a hot flash.
Oh, okay.
Yeah. And then one of our former faculty who's graduates now, Dr. Willapur, they did a quick sort of a case report and review of literature looking at metformin insulin resistance and reduction in hot flashes using metformin. So that was something very interesting. But most of the time, just like you mentioned, it's just listening to the patient. So when they have a long list of things and they're going through the transition, just taking a few minutes and just sort of listening or asking, many will tell you how miserable they are.
Yeah, for sure. Yeah. Let me see if there was a question in the Teams.
I have a question.
Oh, yes, go ahead.
Yes.
Sorry, let me try to turn up the volume and well, it's max. Okay. Go ahead and we'll see if hopefully we can hear.
So the WHI did show a reduction in onset of diabetes with women on hormone therapy during the WHO studies as well. That I recall, they didn't have the pathophysiology behind that. And there was a thing about metformin helping hot flashes. I heard that through in the conference room they're currently on. Is there any understanding that you guys have of how hormone therapy can minimize diabetes onset? Has that been discovered?
Sorry, I may not have caught a lot of that, but there's definitely associations with increasing insulin resistance and potentially people with more vasomotor symptoms have associated with a higher risk of developing diabetes. So it's not something that we're using hormonal therapy right now as an indication like for prevention of diabetes or progression. But it's definitely something to worthy of a lot more study there.
Yeah.
Sorry.
So one of the reasons why I asked that is you mentioned UofL. Can you hear me?
Sorry, it's a little difficult for us to hear in here. Maybe if do you mind typing it into the chat and then I can read it? Sorry.
I increased my volume. Can you hear me any better now?
It's a little faint. I think it's tech issues on our end with the speaker. Let me see if I can try to change.
Well, the reason why I watch is UofL, which you mentioned, is conjugated equine estrogen and vasodoxifene. So I think that's a drug that has a lot of potential of becoming a very common used hormone therapy because of its mix-up, because it's breast neutral. It's either antagonistic or neutral on the breast. So the pathophysiology of why hormone therapy can minimize the risk of diabetes or help diabetic control related to more the conjugate equine estrogen, not the progestin, then that could potentially be something that might be beneficial to a lot of women that are pre-diabetic or diabetic.